Well, good afternoon, everyone. This is Brian Robson, the Medical Director here at Healthcare Improvement Scotland. And welcome to this, the fifth in our QI Connect session for 2018. I apologise for the slight delay, but I'm sure you'll be delighted with the session today. As you know, QI Connect offers an opportunity for colleagues across health, social care and beyond to connect around the areas of innovation, improvement and integration. And we've designed these sessions to be short, interactive and recorded to allow access at a time that suits you. I'm now going to pass you over to Jennifer Graham to tell you a little bit more about the technology. Good afternoon, Jennifer.
Good afternoon, Brian, and good afternoon to all of our QI connectors joining us today. So I just have a couple of quick housekeeping slides to get us started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll tell you a bit more about how to do that in just a moment. And just a reminder, if you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So as Brian mentioned, these sessions are designed to be a fun, interactive learning experience, and we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. There will be an opportunity for Q&A at the end of the session, and also just to note that we'll be sharing hyperlinks within the chat function to any resources mentioned by our speaker today. So this is the fun interactive part starting. So we're keen to find out where you're joining us from today. And I'm just going to ask you to click on the annotation tool, and just to note that you'll be able to use that on the map slide that's just coming up. So if you just click on the annotation tool circled in red, and then click on the arrow icon, and then click on the map to let us know where you're linking in from. Welcome to Brian in the studio.
So while we're just waiting for folks to join us on the map, Jennifer, we're expecting around sort of 170 people or so?
Yep, 170 people. And QI Connect now reaches, so Brian's just about to tell you, 60 countries. So we'll just maybe give people just a little moment just to be able to let us know if it's not going to work. We can certainly move on. Yeah,
it certainly looks as though Kirsty and Jackie are telling us that the pen is, yeah, who would have technology? I don't know, Nigel from BT, if you're on the call, I don't know if you can turn the annotation on just now, or whether we might just move on. Okay, thank you very much, Nigel. So it looks as though it's now turned on. So Margaret, Arvin, Fran, Alex, how are you doing? Oh, there we go.
Oh, this is Gisela, welcome. This is where the UK starts to disappear with all the QI connectors.
Yeah. There we go. Good to see you all joining us from all over the UK and abroad. Oh, welcome Joseph from Montreal. Good to see you on the call, Joseph. And Karen's out in the middle of Pacific. I hope you're finding your way back to land shortly. So good to see so many people on the call, and thanks very much, Jennifer, for getting us familiar with the technology, and for Nigel from BT helping us with the technology there as well. Hi, Kathy. Looks as though you're in Boston. Welcome. Well, we're delighted to say that we're 794 organisations that use QI Connect regularly as a quality improvement resource. But let's go straight to the competition. So again, your fingers are on the buzzers or your fingers are on the arrows. And as Jennifer mentioned, we've got more than 60 countries now linking in with QI Connect. And I'm going to name a country, and if you can put your arrow on that country, you'll win a wonderful prize. And the country flag today is Pakistan. Hard lines, Alex. Oh, there we go. So we've got at least two winners there, but we've got the first person on the line was David Greer from Northern Ireland. David's a consultant paediatrician from the Southern Health and Social Care Trust in Northern Ireland. Well done, David. Mari, you were a close second. Alex, you eventually got there. But well done, David, for that, and delighted that we can pass on to you one of our much admired QI Connect mugs. So we'll swing that past Northern Ireland in the next couple of days. But we're always delighted to just show the huge amount of organizations' wonderful logos. We now have 24 slides with the logos of QI connectors from all over the world, from those 60 countries. It's always wonderful to be able to just flick through and just take a look at the people that are joining, from health, social care, from education, from government, from third sector, from hospices, all over the world. Tremendous to see so many of you join QI Connect. And it's always a great privilege to be able to say that the whole of NHS Scotland joins QI Connect, and it's so wonderful to have you on board. And for the first time, we have, again, organisations from across the UK and further afield joining us, so you're all very welcome as first-time QI connectors. And we're always delighted with the universities and higher education. We have now 68 universities from across the world linking in to QI Connect. You're all very welcome indeed. And a very particular welcome to Leslie Dawson and the University of Edinburgh Oncology Society for being great supporters of QI Connect and the person-centred approach that you're taking to cancer care in Scotland is one of the areas we'd like to shout out today. So you're very welcome to QI Connect. We're also always delighted to highlight that QI Connect is recorded, and all of the recordings are available free on the Healthcare Improvement Scotland website to be used time and time again. And we know that many of the higher education facilities use them in classroom teaching and learning, and you're very welcome to those. We're also delighted, as always, to call out the International Society for Quality in Healthcare and also to the Health Foundation, a UK charity committed to advancing improvement in health and care, and the Q initiative, working with NHS Improvement in England, trying to connect and accelerate improvement through a wide network of improvers across the UK. So you're all very welcome and delighted on QI Connect to have the team, and a big shout out to Sean Mayer, who took over and helped last month when I was unable to do QI Connect. Sean is now an honorary part of the team, and this is a small team that bring QI Connect to you on a regular basis. And we'll hear from Mary McPherson, the head of the Person-Centred and Quality Unit in Scottish Government. We'll hear from Mary a bit later in the call as our first questioner. Remember to please tweet as you learn, and a big shout out to Alex Sterling, who's not in the studio today, but is working remotely to build the Twitter activity, just to widen our reach as always. And this brings us to today's QI Connect speaker. Our QI Connect speaker today is a decorated Vietnam War veteran. He's been a healthcare leader for almost 40 years as a leading cardiac surgeon and a system leader of one of the highest rated healthcare systems in the United States and now internationally. Dr. Toby Cosgrove is the immediate past CEO and president of Cleveland Clinic. Cleveland Clinic is has a world-class reputation for clinical excellence, innovation, medical education and research. And Toby has led the organization for more than a decade. And he's put patients and patients' experience along with patient outcomes at the center of innovation and quality in that organization. And I'd like to give a big welcome to Dr. Toby Cosgrove. Good afternoon, Toby.
Well, good afternoon, and thank you very much for the opportunity to be able to chat with you today. I'm most appreciative for this opportunity. And maybe I could go to my first slides.
Thank you, Toby. So I've given the presenter rights over to you, so that you should be able to collect them yourself, I think.
Hold on. 1 second.
So what we can do, Toby, is I can move to the next slide.
Hold on. We're all set.
Okay, thanks. Thanks, Tim.
So I'd like to tell you a little bit about the Cleveland Clinic. It was founded in 1921 by these four gentlemen who served together in World War I and realized they could do better working together than they could do independently. And they built this initial Cleveland Clinic building, which was designed to have three things: to care for the sick, to investigate their problems, and to educate those who served. And we continue to have that motivation today. We are an unusual organization. I don't think there's one like it in the United States. We're not-for-profit. We're a group practice with 3,600 physicians. We have physician leadership, which is elected by the organization. We're all salaried with no financial incentives. We have annual professional reviews, and all of us have one-year contracts. I had 43 one-year contracts over that period of time. We're now 52,000 caregivers globally, 3,700 professional staff, and 2,000 advanced practice providers. Our locations are principally in Cleveland and Northeast Ohio, where we have the main campus and 10 community hospitals. We also have facilities in Toronto, Las Vegas, and a major clinic in Fort Lauderdale, West Palm Beach. Our international activities are in London and in Abu Dhabi. This is our main campus, which has become a highly technical facility. It has the highest acuity patients of any hospital in the United States. And that is because we have moved a lot of things like the capabilities out of the main campus for obstetrics to the communities. And so this is a very high intensity hospital with about 4,500 cardiac procedures, and about 20% of the hospital is intensive care beds. Our international activities are in Abu Dhabi, where we have a 4 million square foot facility, which is completely staffed by some 5,000 Cleveland Clinic caregivers. And we are preparing a presence in London, which will be opening in 2021, about a 200-bed facility and outpatient facility adjacent to it. Currently, we're seeing some 7 million outpatient visits with over 220,000 admissions and over 200,000 surgical procedures on an annual basis. One of the things we have done is reorganize our healthcare delivery in a very unusual way. Most hospitals are organized around departments of surgery and departments of medicine, which are really the guild system. We thought that it would be preferable to organize around patients' problems, and so we organized in some 18 what we call institutes. An example of this is a Heart and Vascular Institute, where we brought medicine and surgery together. So we have cardiac surgery, cardiology, vascular surgery, vascular medicine, all in the same organization. We found that this has a number of advantages. One, it centers around the patient and brings the expertise of both medical and surgery together. It eliminates the competition between medicine and surgery, and it spurs innovation, looking at difficult problems and saying, how can we combine our activities that will be most useful for the patient. We're delighted that we have been looked at as one of the top hospitals in the country over the last several years by U.S. News & World Report, and very good company. And one of the major issues is patient satisfaction. And if you look at across our entire organization, the patient satisfaction is in the 62nd percentile in the country. And on the main campus in our Florida facilities, which are in the 90th percentile. So we have put a major emphasis around patient satisfaction. Quality is something that we measure incessantly. And this is just one measure about hand hygiene and washing, which we monitor closely. We looked at all-cause readmission, which we have worked hard on. Because we have the highest acuity in the country, it is difficult to drop this as much as we'd like, but we have made significant progress on this over the last several years. I think probably one of the most important things we do, rather than just looking at reputation, is we report on an annual basis outcomes. And I've asked each one of our institutes to put together measurements of outcomes, the good, the bad, and the ugly. This is available on our website, and it's also available in paperback form. We do this for two reasons. The first reason we do it is because as we look at our outcomes on a regular basis, we always find something where we could do better, and we then direct our attention to try to improve the quality of that outcomes and continue to monitor it over time. The second reason we do it is we consider ourselves a community resource, and in transparency, I think it's important that we report to the community exactly how we are doing in the various outcomes. So this has been an ongoing project now. We're now in our 15th year of doing this across the board and being very transparent about how we do. We feel that as we go forward and continuing push towards value in healthcare, that it's going to be important to standardize care. And therefore, we have developed what we call care paths, which is we feel they recognize the best way to do various things. And we've seen as we have adhered to these care paths and everybody follows the care paths, we've seen the quality improve and the costs come down. And gradually we're implementing those and putting them in our electronic medical record. Certainly if you're building a car, you wouldn't want everybody to do it their own personal way. You would not have great quality and you would certainly drive up the cost, and we feel the same way about dealing with healthcare problems. We're an educational institution. We have our own medical school, which is done in conjunction with Case Western Reserve University, and this is one of two tuition-free medical schools in the United States, and we are in the process of building this new facility, and again in conjunction with Case Western Reserve University. We think this is going to be a rather unique facility. It will house the medical school, the nursing school, the dental school, and the physician's assistant school, all coming together and learning together. We feel that healthcare is a team sport, and the way we are currently educated is in silos, and we want to break down those silos right from the get-go and begin to have everybody learning together and working as a team, because we think that this is what ultimately is going to improve the quality and the sophistication of healthcare. We have been a teaching organization for a long time. We have almost 2,000 residents and fellows in training at any one period of time. We also continue to be a research organization. We have some 2,600 research projects, and over the last 4 years, they've had 130 citations in the literature. Out of that research has come a number of intellectual processes. We've filed for 3,600 patents and had 1,200 granted, and those have resulted in products and companies that have spun off from the Cleveland Clinic. Some 80 companies have resulted from our intellectual capital. We are, however, really an organization that feels that the reason for our being is that we are here for patients. We educate for patients' long-term well-being. We research for improvement in their care, and we all take care of patients. And this has been our mantra for a long period of time, and it brings everybody together and makes us understand why we're in healthcare and unites us around the patient's well-being. One of the things that we want to do is make this a patient-friendly organization. And we've done a number of things because we feel that quality in healthcare really revolves around three things. It revolves around the clinical outcomes, which we measure with our outcomes books. It revolves around the physical experience, and I'll tell you a little bit about that, and as well as the emotional experience in the hospital. As far as the physical experience is concerned, we have put patients we've put employees or the Cleveland Clinic caregivers in red coats at all our entrances to help people navigate through our facilities. We have worked hard at the architecture and used art to enliven that. And also it acts as a wayfinder for people to find their way around the organization. We've done things to make us more friendly, and there's nothing better than finding a dog either in the lobby or visiting the children or on the oncology ward. But the main thing that we did to change the focus of the organization a number of years ago, we brought everybody in the organization together around these tables, whether you were a physician or a nurse or you drove a bus, to talk about the Cleveland Clinic experience. And this is a half-day training session, and as they came out, we gave everybody a badge that said caregiver. We refer to everybody in the institution as a caregiver, whether you are a surgeon or you are part of the dietary facilities, you are referred to as a caregiver, and that has done two things. It has improved the engagement across our organization of all of our caregivers, and it has also improved the patient experience no end. So Theodore Roosevelt, former President of the United States, said that no one cares how much you know until they know how much you care. And in order to foster this, we developed a patient or employee caregiver training film, which was in fact developed in-house and is available on the web, and I'd like to share that with you now.
Thanks very much, Toby. That was amazing. We're just going to link into the video just now, and Jennifer's just setting that up for us. Already we're getting amazing comments in the chat box, not just about the dog, Toby, but the concept of caregiver, the concept of team training, team development. All of that is going down very well in the chat box.
Good.
And Jennifer, how are we doing? Okay, Jennifer's just going to show this amazing video just now. Whoop. Yeah, we're just getting the technology sorted. Tim, could I ask you just to pass the ball to Jennifer Graham just below you on the chat box? That says we're just going through this wonderful video now. Toby, over to you.
Well, I'm delighted to be able to share that with you. Certainly, if anybody wants to use it, they're more than welcome to it. It's you can get it on YouTube and just look under empathy.
Toby, thank you so much. That was the most amazing outline of the development of the service, the purpose, the meaning, and finishing with that video was just astounding. As we said at the beginning of the talk, there's a lot of questions coming through. I'll take a look at those just in a moment. And Jennifer, we might just want to invite Mary to say hello again. So we have Mary McPherson with us. Good afternoon, Mary.
Good afternoon. Thank you, Toby, for that really powerful presentation. I was particularly struck by the way in which you described quality and the way that you think about quality in your organisation. So thinking about clinical outcomes, physical experience and emotional experience, and thinking about that last one and the video that you've just shown, it's sometimes said that the soft stuff is actually the hard stuff, and you've got some really concrete data that you shared earlier on about some of the aspects of quality that you're able to measure in the organisation and the kind of improvement in outcomes that you've been able to see around things like you showed the hand hygiene stuff and the reduction in readmission. I'm really interested in how the video is being used in the organisation and how you're measuring or understanding its impact and the changes that it might be making.
Yeah, we use the video with every new caregiver as part of their onboarding process. And it has been shown around the world now. It's had something like 2 million downlinks and been shown on virtually every country in the world. And it's interesting, it's been picked up not just by hospitals, but it's also been picked up by a lot of different industries because I think it speaks to empathy and the importance of trying to put yourselves in someone else's shoes and experience and have this understanding of their experience as they go through the healthcare process. The interesting part of it is starting about 12 years ago, we created out of an experience that I had. I'll tell you the story because it's embarrassing. I was at the Harvard Business School and they did a case study on the Cleveland Clinic, and I was answering questions, and a student said, Dr. Cosgrove, my father had mitral valve prolapse, and we know that you've done more of those operations than anybody else in the United States, but we didn't come to you, Dr. Cosgrove, because we heard you don't have empathy. Dr. Cosgrove, you teach empathy. I can't remember anything I said after that, but I went back and reflected on my career, and it has been all about the technical aspect of doing surgery and not about the soft stuff. And coming out of that, I wanted to put emphasis on this for our organization, so I created a C-level position, the Chief Experience Officer, which was the first one in the United States. And out of that, we started out of hospitals more than 1,000 beds. We were last in the United States, and we went from last to first over about a 4-year period of time, really putting our emphasis on understanding the patient experience and trying to deal with it as a group of empathetic caregivers.
Thanks very much for that, Mary. Thanks, Toby. In the chat box, we've got Jackie Welsh, who's an improvement advisor, saying that everyone should use that video. It should be used everywhere. It certainly gets to the heart of what we should be doing in terms of thinking about what other people are considering and the impact on patients and others. And Arvind Varaya, who is a consultant physician and the lead for medicines in the Scottish Patient Safety Programme, says similarly. He says, the stories that walk past us every day. It really has great power to it.
We've been very pleased with it.
Yeah. Thanks, Toby. We've got Graham Cumming, who's the Innovation Champion at NHS Lothian here in Scotland, is recommending your book, The Silo Effect, talking about the work that you've been driving, Toby. Adele Sheridan's got a question. Adele is a project officer here at Healthcare Improvement Scotland, and it was to do with the development of both the pathways and the concept of caregiver, and she wondered how you involved patients and carers in the development of that sort of work.
The pathways were essentially built around the technical aspect of looking after whether it's a hip replacement or cardiac operation or dealing with sepsis. Our aspect we have on all of our institutes have former patients giving us back input into how we can better improve that aspect of their care. And so we incorporate those ideas on a regular basis.
Thanks for that, Toby. We have a number of comments again about the video. People asking, can they use the video? I think you said, Toby, use it widely. Is that right?
Everybody's absolutely welcome to it. Take it and use it. It's on YouTube. It's free. And I encourage you to use it as you see fit.
Thanks again. Toby, Sarah Jenkins has been active in the chat box. Sarah is a consultant neuroradiologist here in Glasgow. Amongst the comments and questions that Sarah has asked is she's interested to know more about the performance management in Cleveland Clinic. And I guess some of this started in the chat box when you mentioned the one-year contract. Could you say a little bit more about the thinking behind the one-year contract and how performance is assessed in your system?
Yeah, we've had a history of having one-year contracts forever. I personally feel that having, somebody having tenure is an invention of the devil. I don't think anybody should be assured of their position. And as a result, we have of this that everybody in the organization is on this same one-year contracts. They are reviewed on an annual basis by their peers, and it is done with as many metrics as we can find to measure. And people are not just rewarded on the basis of, and by the way, the salaries are adjusted similarly with their people's contribution to the organization. For example, somebody may be 90% clinical, somebody else may be 90% research, but it is looked at as the total sum of the contribution to the organization, and we look for that contribution. Interestingly, the total turnover of the organization, the physician portion of the organization, is somewhere between 4% and 5%. The majority of those are leaving on their own, but we do have a very stable workforce amongst the physicians. I think it's interesting that people come here. Cleveland, Ohio has not been noted to be the best place in the world for skiing or surfing. So people do come here to work, and they're attracted to come and work at the Cleveland Clinic. Now, one of the interesting things about the Cleveland Clinic is the way we keep people is that we provide them as good working conditions as we possibly can. So they never have to worry about a contract. They don't have to worry about their malpractice. They don't have to worry about hiring secretaries. All that is provided by the organization, and we ask the physicians to do physician work, not to do the business work.
Thanks for that, Toby. Arvind Varaya again, consultant physician in Edinburgh here. He's interested in different cultures and what different cultures and issues you may have come across setting up institutes in different countries. what are the big differences that you might have encountered?
Interestingly, the institutes, the place where we had done institutes had been in Abu Dhabi, and we had essentially adopted that same approach there. And people probably are wondering where the physicians came from, and I'll always ask where the physicians came from in Abu Dhabi. We had 12,000 physicians apply for privileges. We hired 350. 80% of those are from the United States, 20% from Europe, and a third of those are from Cleveland. We thought if we were going to try and replicate the Cleveland Clinic culture, we needed to have Cleveland Clinic DNA there. And so the leadership is essentially people who have joined us from Cleveland, who joined the facility there from Cleveland.
Thanks, Toby. Steve Gilbert, who is a consultant anaesthetist and pain specialist, he's calling from Townsville in Queensland, Australia. Steve's interested in whether Cleveland Clinic have built any connection to community education and health promotion within communities.
Yeah, we have. It's very interesting that in the United States we are looked at as our contribution to the community in the financial terms, and we have almost $900 million of contribution to the community on a $9 billion budget. And so we have reached out to the community. One of the things we did, which had a major impact in the community, is I, being a thoracic surgeon, had seen the ravages of smoking. And so when I became CEO, we decided that we would not have any smoking on our campus, and that means in our garages or in our land around the facility. And then we went to not hiring smokers. And we offered people who were applying, who turned out to be positive for nicotine, we gave them smoking cessation. And as a result, that actually spilled over into the community. And we saw our smoking incidence at the Cleveland Clinic now is 5% amongst our employees, where it's about 23, 24% in the community before this, and now the smoking in the community, is about 15%. So, we thought we need to model what is appropriate personal health.
Yeah, that's quite. I'll let you get your breath back there, Toby. I must say, in the studio here, we all kind of our mouths opened wide when you said that was a prerequisite for hiring. We can see how that makes good sense from individual and public health. But interested in what the staff reaction was to that.
The staff reaction, actually, we didn't fire people. We just didn't hire people, and we offered everybody who was there smoking cessation. Okay. We thought it's important that we model what appropriate health care was. Interestingly, I'll tell you a little bit about our concerns going in. The highest incidence of smoking in the hospital is, interestingly, with the respiratory therapists. And we were concerned we were not going to be able to hire any respiratory therapists. Happily, we found a group of respiratory therapists who didn't think smoking was important.
Got it. Now, listen, Mary McPherson's still with us, the head of the Person-Centered and Quality Unit. Mary, you've got another question for Toby.
I do, and just kind of echoing that discussion which we've just been having about hiring policy. I think we've got, it's interesting to reflect on what that might mean for Scotland. We do have quite a lot of data about our healthcare workforce, and particularly the nursing workforce in Scotland, where we have higher rates of smoking and obesity than we have in the general population. So it's kind of fascinating to think how can we further support our workforce. And I guess that kind of links to my question, which I want to ask, because often we focus on the patient experience. I think we've got a lot of evidence which suggests that the experience of patients is very closely linked to the experience of staff, and you've been talking a little bit about that. I'm interested in what data you've got about the impact of the work you've started to do around empathy in terms of its impact on staff and their reaction to that, and potentially it's linked to well-being or not in the staff population.
So let me talk a little bit about staff, because we in the United States are dealing with a major issue about burnout, particularly amongst physicians and across all of the healthcare workers. And I think I have to link that with looking at the causes, and I think the causes are, one, loss of autonomy amongst physicians. I think the second thing is the electronic medical record, which is now, is anything but physician and patient friendly. And third is the explosion in knowledge. And if you look at the total amount of knowledge that in healthcare, it turns out that the total amount of knowledge in healthcare is doubling every 73 days. There are currently over 800,000 journal articles a year and some 5,600 journals. And for anybody to try and keep up with this is almost impossible. So I think this is a major concern. We have done a lot of things to try and improve this amongst the rate of burnout. We've looked at how we could improve the understanding of the ability and ease of using the electronic medical record by taking away and consolidating a lot of the clicks and also making the sign in and sign out easier. We have begun to look at use of scribes for physicians so that they can actually see the patient and have someone develop the record at the same time. We have gone to asking physicians, and it turns out that we surveyed our physicians, and less than half of them were getting annual physicals. So we gave them all a day of personal health and encouraged them to get their physicals. We have tried to enhance the communication across the organization in every way possible, using television, emails, meetings in public. We've asked for their feedback about how we could make life easier for them. And in fact, the incidence of burnout amongst the U.S. physicians is just slightly over 50%. And happily, we're at about 37%, but still not happy with it. So this is, I think, not unique to the United States, but it certainly is a fact of life. And I think we're, going back to electronic medical record, I think we're just seeing the very first of the electronic medical records, and ultimately we're going to see something that's substantially more sophisticated. Ultimately, I think it will be voice activated and not require typing. So this is a big issue. You might be interested to know that we put out a major push around the health of our employees, not just smoking, but we also changed all the food in the cafeterias. We took away the sugared drinks. The organization has got some 100,000 employees, and we've lost over 500,000 pounds. We've offered, we're self-insured, and we've seen the health of the organization improve, and the cost of looking after our caregivers come down substantially over a period of time. So we were going up at 7.5% a year 10 years ago. Last year it went down 2% to look after per patient. to look after our employees. So we got a healthier workforce, and it's costing us less.
Well, thanks for that question, Mari. Toby, that is amazing. The chat box lit up when you started talking about burnout and the impact, and also that it looks as though we're looking at David Greer, our QI Connect mug winner from Northern Ireland. He's going to send the policy on to senior managers and see what happens around the smoking. But it sounds as though you've got that as a whole package of interest in the health and well-being of your staff. And what you mentioned earlier was that is impacting on the health and well-being of the people that you serve in communities as well, right?
Yes, that's correct. Because and it has been a very positive influence, and you know we look more and more at the social determinants of health care, and clearly they're related to education, they're related to jobs, they're related to food, housing, and so the organization has really put its emphasis on three things: great health care for our patients, great employer, and we're the largest employer in the state of Ohio. And all of our philanthropic activities hinge around education and trying to improve the education of people in the community.
Well, Toby, you've described very well for us today on QI Connect the background to Cleveland Clinic and how Cleveland Clinic has evolved over the years. I'd like to thank you on behalf of all the QI Connectors. We're coming to the top of the hour. I'd like to thank Tim in the Cleveland Clinic and your office for helping arrange things today, and a big shout out to Mari McPherson at Scottish Government for supporting us, and to all the QI Connectors who've put forward questions in the chat box. Thank you very much as well. Big shout out to our next QI Connect speaker. Danielle Martin is one of the most influential Canadian healthcare leaders. She's a best-selling author and media commentator and a physician in Canada. So we're looking forward to discussing Canadian healthcare and the big lessons from overcoming challenges in Canada from Danielle on the 21st of June. And just to remind everyone of the amazing lineup that Jennifer and the team have brought together here in QI Connect in 2018. You can see we're having a short summer break, and then we'll be back with Brenny Brown after the summer. But Danielle Martin on the 21st of June. And just to close off by thanking everyone and just reminding everyone to follow us on Twitter. Thank you very much and have a great rest of the day.